All right, great. So on my clock, it is 12 o'clock. So why don't we go ahead and get started? I just want to welcome everyone again to Medical Grand Rounds at the University of Colorado. Just as a reminder, CME and mock credit are available for all Grand Rounds this year. And so please use the link that Kelly Redard will put in the chat to claim your credits. I want to remind everybody to please use the Q&A feature throughout the talk to ask any questions of Dr. Davis today. Myself and the Chief Medical Residents will be gathering those questions and we'll use them for discussion at the end of the talk. So please put them in as the talk goes on, and we'll make sure to allow Dr. Davis to finish her talk, and then we'll save those for the end. I don't have any other big announcements or updates for the department today. And so without any other further ado, I will introduce Dr. Lisa Davis. She is an associate professor in the Division of Rheumatology here at the University of Colorado. Dr. Davis was born in Arkansas. She then moved to Utah and attended BYU, where she graduated cum laude as an undergrad. She then came to Colorado for medical school, and she stayed here for her medical school, internship, residency, as well as her rheumatology fellowship. So as Dr. Chope would say, she is clearly very well trained. Since graduating, she's remained at Colorado as a clinician and educator, and of course, as a health sciences researcher. I have known Lisa for a number of years, and I know her today as an incredibly dedicated educator. She has run several courses in the medical school. She's obviously a frequent educator within her rheumatology fellowship. And then, of course, she's one of our associate program directors in the residency program. Within the residency, she's in charge of focusing her efforts on mentoring scholarship for all of our residents, which has led to an increase in scholarship over the past several years, along with her team of scholarship advisees. And she's also one of our advisors to residents who are going to pursue subspecialty training, given her own background. Her research work has been funded by a number of institutions. She's been funded by the American College of Rheumatology Science Development Award, the Veteran Affairs Research Enhancement Award. She also has received grants from the NIH as well as the NIAMS. Most recently, her work is focused on health literacy, English language proficiency, and the assessment of disease activity and medication compliance in patients with rheumatologic diseases, as well as the effect of rheumatologic diseases on people of different races and ethnicities. And today she'll be talking to us, as you can see her title here, about the impact of a health literacy universal precautions toolkit on rheumatoid arthritis clinical outcomes. Dr. Davis, thanks for joining us today.
Thank you so much, Dr. Connors. I really appreciate it. And thank you to all the panelists. So let's just dive in, okay? All right, so disclosures. This work was supported by an investigator-initiated studies grant from UCB Biopharma. Acknowledgements. I'd like to first and foremost acknowledge Dr. Joel Hirsch, who has been my health literacy mentor and a major driver of our shared work. I'd like to also strongly acknowledge Dr. LaRon Kaplan, who has been one of my mentors since I was a resident. And he helped mentor me in statistical and pharmacoepi. Dr. Angela Keniston, who has been a biostatistician, who has been just so helpful for me in so many ways. And then my colleagues at the Denver Health Rheumatology Clinic, Drs. Dennis Boyle, Jennifer Stitchman, Itziar Kinzanos, and Joanne Zell, who really helped with the actual performance of the study. Okay, so first of all, let's talk about our learning objectives. First of all, we're going to talk about understanding health literacy, its impact on health outcomes, and its role as a mediating determinant of health. We're going to then talk about understanding the impact of limited health literacy on health outcomes, specifically in the microcosm of rheumatology. We're going to understand the health literacy universal precautions toolkit and its modification for rheumatology, and understand the impacts of implementing the Health Literacy Universal Precautions Toolkit for Rheumatology, or Toolkit R, on clinical outcomes in a rheumatology clinic. Clinical case number 1. Ms. Smith is a 72-year-old female with a new referral to rheumatology with a diagnosis of rheumatoid arthritis based on positive serologies and synovitis. She was started on methotrexate 15 milligrams by mouth weekly by her primary care, with the anticipation of seeing you within the month. You see her approximately 1 month after she was started on methotrexate. And on review systems, she notices a worsening fatigue, but that her arthritis is better. You ask her what medication she is taking, and she responds, "Oh, I'm taking the new one, the one that starts with an M." Okay. You get back labs from your visit and you find that she has a new neutropenia with a white cell count of 1.5, an ANC of 400, and worsening anemia. You call her back and you go over her medications more thoroughly. And what do you find? Okay, I want to give you a moment to kind of think about that. So you find that she has been taking a pill of methotrexate daily rather than her 6 tablets weekly. So what are the risks of not communicating effectively with our patients? A patient may not understand their disease, may not understand their disease prognosis. A patient can be disengaged from their own healthcare. You can have incorrect medications or incorrect doses, and this can result in harm to that patient. A patient may lose trust in the entire medical system, or a patient may not return to you because they do not have trust in you. So let's talk about clinical case number 2. Ms. Jones is a 35-year-old female with a past medical history of rheumatoid arthritis. She comes in to see you and is given a disease activity form. Okay, put a pin in that. We're going to talk about that here in a second while she is waiting for you. You ask her how her arthritis is doing, and she says, pretty okay. And you ask her how everything else is going, and she relates that she's been feeling poorly with a new diagnosis of degenerative back disease. Her physical exam does not show any synovitis. The patient global activity, or PGA, which is shown here, and this is a measure that's used worldwide as part of disease activity measures for rheumatoid arthritis. And she indicates that she's doing very poorly. Okay. So you are trying to decide what you should do with her medications. By any disease activity measures that incorporates the PGA, she has high disease activity. What do? Do you believe the score and increase her immunosuppression, or do you ignore the score and keep her medications the same? I want you to think about that and percolate that for a moment. Okay. So we're going back to our learning objectives. And our first learning objective that we're going to focus on is understanding health literacy, its impact on health outcomes, and its role as a mediating determinant of health. So what is health literacy, right? So as defined by Healthy People 2030, which is I'm going to say a program put together by the CDC, personal health literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and for others. Health literacy is composed of literacy, but also numeracy. Health literacy can be impacted by so many things, but some of the examples that it can be impacted by are unfamiliar terms, so using medical jargon, the need to interpret statistics and risks to oneself, emotional responses to new or scary diagnoses, and complicated self-care. Medical care is complex, okay? And routine healthcare activities, such as receiving instructions at a doctor's office, taking medications, preparing for a screening test, choosing a treatment option, these all require sophisticated skills of our patients. And health information is often presented in such a way that proficiency in literacy and numeracy is needed to make informed health decisions. There is a strong and consistent relationship that exists between literacy and health outcomes. The relationship between health literacy and the social determinants of health is less well understood and less well studied. So there are many authors who have proposed health literacy as a mediating determinant of health. I think of it as kind of a confounding variable when I'm thinking about statistics. Okay, so health literacy mediates the association between socioeconomic status and specific health outcomes. And these authors have proposed that improving health literacy can potentially alleviate the effect of certain underlying socioeconomic determinants that contribute to health disparities. So let's take this diagram from Healthy People 2030, and they are looking at the social determinants of health. These include education and access to quality, economic stability, social and community context, the neighborhood and the built environment, healthcare, and access to quality. So health literacy, as we talked about, it's composed of literacy and numeracy. And so that health literacy is impacted by the patient's education and access to quality. And the health literacy itself impacts healthcare and access to quality. So to give a little bit more information, when we're talking about literacy and numeracy, so we're talking here about US adults ages 16 to 65 years of age. And this is on the PIAC scale, which is the Program for the International Assessment of Adult Competencies, or PIAC, okay? And if we, use the thumbnail of one is getting by, just kind of bare necessities, like I know how to count money and buy things. I can read street signs, those sorts of things. So our levels of literacy in the US, we have about, call it 18% who are level 1 and below. And if we look at numeracy, we have approximately 30% who are level 1 and below. So we have in my opinion, a large proportion of our population who are not at goals or not at high levels, minimally to say, of literacy and numeracy. So again, health literacy is composed of literacy and numeracy. We have complex care environments and regimens, and these require even higher health literacy. Health literacy impacts health outcomes, and health literacy is a mediating determinant of health. It's both impacted by and impacts social determinants of health. One of the goals of the Healthy People 2030 is to increase the health literacy of the population. I would propose that while this is a laudable goal, I really do, it's not within my circle of control. I am a pragmatist at heart, and so I think to myself, well, what can I do? I can't necessarily impact all the education for people in the United States, but I can make healthcare less complicated for others. Okay. So again, for our next learning objective is we are now going to talk about in understanding the impact of limited health literacy of health outcomes, specifically in the microcosm of rheumatology. So in general, okay, limited health literacy is associated with negative health outcomes. It's associated with increased utilization of services, including emergency care and hospitalization. And it's associated with higher healthcare expenditures. So this is in all sorts of different conditions, hypertension, hyperlipidemia, et cetera, et cetera. In rheumatology, in the microcosm of rheumatology, limited health literacy has been associated with worse functional status, increased pain, physical limitations in rheumatoid arthritis patients, also with discrepancies between patient and provider assessments of rheumatoid arthritis, and in general, not understanding model disease states. What do I mean by that? It is a proxy for understanding the goals of care. So limited health literacy can impact health outcomes. This is true both within and without the microcosm of rheumatology. So for our next learning objective, we're going to be talking about understanding the health literacy universal precautions toolkit and its modification for rheumatology. So what are universal precautions? So for many of our residents, this has been a part of your life, your entire training, right? But universal precautions were really introduced in around 1985 to prevent the transmission of bloodborne pathogens from exposure to blood and other potentially infectious materials. When you practice universal precautions, you minimize the risk for everyone. So what are universal health literacy precautions besides a mouthful, right? When you practice universal health literacy precautions, you minimize the risk for everyone. You structure healthcare services to minimize risk, and I would add, maximize the efficacy for everyone. So again, but why universal health literacy precautions? So I want you to ask yourself these questions. Should we screen everyone's health literacy as they come into clinic? I would say no. And the reason why is there's been clear evidence of an association between shame and literacy screening. Okay, so should we screen only some people's health literacy? Ask yourself that. I would say, again, no. How would you feel if you were targeted for screening for health literacy? You could say, is it because of I only completed some of my school? Is it because of my age, my gender, my race, my ethnic background? That doesn't seem equitable. That doesn't seem just to do for our patients. So should we just assume that some people have poor health literacy? I would also vote no on that. Making assumptions about people rarely gets us anywhere. Should we just assume that we're always the best health communicators? I'm going to say no. And at this point in my life, I realize that I'm not always communicating the way I think that I am. So the only logical response is to assume that everyone needs to be communicated with in a clear way. I don't care if you have a PhD, a JD, an MD, or if you have finished 4th grade. Everybody needs to be communicated with in a clear way. So the Health Literacy Universal Precautions Toolkit. This was commissioned by the Agency for Healthcare Research and Quality, or AHRQ, for use in adult and pediatric populations. It was designed for use by all staff in a practice, including physicians, nurses, receptionists, business staff. It was developed over 2 years, and it was released in 2010. Its final release had 20 tools. The goals of these tools the goal of this was to create tools that could be used to improve spoken communications, improve written communications, improve self-management and empowerment, and improve supportive systems. So we got our basis of the Health Literacy Universal Precautions Toolkit. Then in 2013, a group of educators created a streamlined or new toolkits to focus on specialty care. When we think about specialty care, when we think about, for example, rheumatology and cardiology that they used here, we have a lot of high-risk medications. And so this was very focused on medication safety. So some of the selected tools included the teach back method, the brown bag medication review, and encouraging questions. I want you to put a pin in that, and we're going to come back into what those actually mean. So from here on, I'm going to call it Toolkit R because the rest of it is a mouthful. Toolkit R has been shown to raise provider awareness and low health literacy. However, prior to the study that I'm going to be talking to you about today, no previous data existed on the feasibility of this or the toolkit's effects on patient satisfaction, medication adherence, rheumatoid arthritis disease activity, or concordance between patient and provider assessment of disease activity. All right, so now we're going to be talking about understanding the impacts of implementing the Health Literacy Universal Precautions Toolkit R Toolkit R on clinical outcomes in a rheumatology clinic. So in our study, our objective was to determine the impact of Toolkit R, the teach back method, the brown bag medication review, and encouraging questions on medication adherence, patient satisfaction, feasibility, and on the effect on the Clinical Disease Activity Index, or CDI, in the rheumatoid arthritis subpopulation. We received IRB approval, and the participants were considered to be the physicians and the physicians in training at Denver Health. The initial training for the rheumatologist and the the fellows and the residents was January 20th, 2017. And then we had a rolling training for our fellows and our residents. The physicians and the physicians in training received in-person training. They had emails, handouts, and summary documents about orientation to the project, approaches to the interventions, how to train residents, and how to enter data into the EMR. Okay, now we're coming back to the specific interventions. Teach back method. So the physicians who were there, they asked the patient in a non-testing manner to state what they needed to know or what they needed to do. For example, what are you going to tell your family today when you get home? Okay, not tell me what's going on, or tell me, what we talked about. Give me a thumbnail. They really were saying, tell me what you understand about the situation. Okay, the brown bag medication review. The clerks who made appointment reminder calls had scripted instructions to the patients to bring in their medications, their supplements, and vitamins. The attending physician or fellow would then perform the brown bag medication review, which is literally pulling out the pill bottles and verifying that the medications were listed correctly in the EMR. We had signs that were posted in English and Spanish in the waiting area and in the patient rooms, and we encouraged the patients to bring in their medications for review. We had a convenient sample of select clinics, and we had a bilingual research assistant who performed additional reminder calls 2 days prior to the patient's visits to remind them to bring in their medications. I want you to remember that part because we're going to come back to that for a second. And then the last specific intervention was encouraging questions. So physicians were scripted to ask, what questions do you have? As opposed to, do you have any questions? When you think about that power imbalance that can be between you as the physician and your patient, do you have any questions? No, cool, see ya. As opposed to, what questions do you have? This is giving the expectations that you want them to understand you and that you want to understand them. Okay, we had our pre-intervention data, which were collected between October 1st, 2016 and March 31st, 2017. We had a wash-in period so that the habits could be formed amongst our staff between April 1st, 2017 and September 30th, 2017. And then we had our intervention period, which was October 1st, 2017 and March 31st, 2018. Data collection. Individual interventions of the toolkit were recorded in a multi-response drop-down menu designed into the clinic's template, and this is recorded by the physicians. The demographics were derived from the EMR, and disease activity were derived from the EMR. So again, back to our primary outcomes and data sources. Our primary outcomes were patient satisfaction, medication adherence, the Clinical Disease Activity Index, or CDI, in the subset of patients with rheumatoid arthritis. So patient satisfaction, we chose to use the data that are given to our hospital through Press Ganey. This is just normally what they would do for patient satisfaction. And this was given to us on a monthly basis as a top box percentage or the top box percentile rank. Medication adherence. So this was measured for rheumatology related medications filled at a Denver Health Pharmacy by calculating the proportion of days covered, or PDC. Okay, the PDC measures the number of days in an observation period in which the patient has the medication in their possession. Medications considered to be rheumatology related included synthetic DMARDs, things like methotrexate, azathioprine, biologic DMARDs, things like JAK kinase inhibitors, TNF inhibitors, gout medications such as allopurinol, osteoporosis medications such as bisphosphonates, and corticosteroids. We excluded infusions. We excluded medications filled through medication assistance programs. And then our last primary outcome was the CDI. And again, the CDI is this is the Clinical Disease Activity Index, and this is specific for rheumatoid arthritis patients. And the CDI is composed of the patient global assessment, the evaluator global assessment, the tender joint count, and the swollen joint count. Just a note, lower CDI is better disease activity, okay? For our secondary outcome and the data source of this, we looked at any change in the mean visit duration that was attributable to the Toolkit R interventions. A study assistant measured the duration of new and return patient visits for 2 providers in a convenient sample of 7 clinics before the intervention and 7 clinics during the intervention. For the analysis, we used STATA 14.2. We use the appropriate measures for the summary data. And then for our regressions, which we'll talk about those here in a moment, we use GEE. And this is because we're comparing the same humans in their first observation and in their during the intervention. Okay, so when we look at our summary data, we had basically no changes in the pre-intervention period and the during intervention period. The only differences that we found were in the visit type. There was a small difference between the number of return patient visits and new patient visits. All right, now when we're looking at the actual interventions and the performance of these, remember I talked to you about the research assistant. Okay, so when we're looking at the normal clinic flow, like we were just saying, hey, this is just, we tell patients to bring in their medications, we are doing our normal thing. We had questions encouraged being documented in the EMR 98% of the time during the intervention period. We had the teach back communication documented 92% of the time. But wow, the brown bag medication review documented on only 36% of the time. This, again, required the patients to actually bring in their medications and then the physician to go through their medications and to document it. So when we had our research assistant call patients and during that period of time to remind them, the extra calls, we were able to get our adherence to this up to 69%. Okay. Now, when we look at the overall proportion of days covered, or PDC, and we look at the stratification of the different types of medications. One thing I want to note, this is just looking at comparing the pre-implementation and the during implementation for all comers. The same patients don't have to be in both periods. We're just looking all comers, okay? So if we're doing the comparison, we were able to increase the PDC in overall about 14%. We were able to increase the PDC for pretty much all the subcategories of our rheumatology-related medications, with the exception of our gout-related medications. It wasn't statistically significant at that point. But overall, just these interventions were able to increase our PDC about 14%. Now, I find this really cool. I'm sorry. But when we look at the proportion of days covered for individuals who were in both periods of time, okay, so they were in the pre-intervention time and they were in the intervention time, and they were on the same medication. So we're able to kind of compare them time to time, right? So if we compare those people between their pre and their during, we were able to increase the overall PDC for those individuals by 22%, all right? And all the subcategories were statistically significant and were improved by these interventions. Really interesting also. So now, again, we are looking only at individuals who were in the pre and the during, and were on the same medications during both periods of time. And if we look at those individuals, and this as a linear regression, and we try to identify what are the factors that are associated with this increase in the PDC, we're able to pinpoint, target, however you want to put it, that the teach back seems to be the most effective in increasing the PDC in these individuals. Also, and this was, let me note, this was by about 8 to 9%. Okay. Also of interest, if we're looking at self-identified ethnicity, preferred language, and insurance, and self-identified race, the increase in individual medication PDC was associated with Spanish speaking, also with commercial insurance, with being white and non-Hispanic. Okay, now moving on, we're talking about the variables that were associated with, variables and interventions associated with a change in clinical disease activity. Now, again, just a reminder, we're looking at a subpopulation now. We're looking at humans who are rheumatoid arthritis, who were in both cohorts, who were both in the pre and in the during, who had a DMARD, okay, so of some sort. It could be a conventional synthetic, it could be a biologic DMARD, but something that says, yeah, this person truly has rheumatoid arthritis. And when we look at these people, and again, a reminder that a lower CDAI is better. We want to decrease the CDAI in these humans. The things that show the greatest contribution to a decrease in CDAI were not our interventions, but rather self-identified race, African American, and self-identified ethnicity, being Hispanic. We were not able to show an impact on the CDAI through our interventions. Talking about the feasibility, I always tell people, it's like, there's two things with my pragmatist heart. If I have the best medication in the world and I can't get the patient to take the medication, it doesn't matter. I also, if I have the best interventions here and I can't make it happen within the constraints of my clinic, it doesn't matter. That's part of the reason why we looked at feasibility. So we looked at, do these measures add significant amount of time to our clinic visits? And we looked at the pre-intervention period. The mean visit duration was 21.4 minutes. During the intervention, the mean visit duration was 20.6 minutes. And when we controlled for the patient visit type, whether it's a new or return, trainee presence, medical interpreter use, there was no significant difference between the duration of these visits. So, aspects not changed by implementation of the toolkit are: patient satisfaction was not impacted at all. Average measures of disease activity in rheumatoid arthritis in both time periods, no statistical difference. Average duration of visit, no statistical difference. But the performance of the toolkit R resulted in improved medication adherence with particularly strong effects associated with the teach-back method. The performance of the toolkit R was feasible. No statistically significant difference between the duration of the visits. And this is the first study to document improved PDC with providers using teach-back communication in a real-world setting. My personal experience, okay? I feel like teach-back and encouraging questions are two easy, feasible ways to communicate with our patients. Brown bag medication review can be very helpful. The example that I gave of the lady who was taking her methotrexate incorrectly is actually an example from one of my experiences with one of my patients I was able to find through doing a brown bag medication review. But it can feel a bit like a time sink, okay? And in our real world experience, brown bag medication reviews were almost impossible to implement every visit without significant support. And this likely reflects the fragility of the patient's medication taking behavior. So some of the discussion points that I want to bring up is, are we as physicians responsible for providing better communication with our patients? Why or why not? And also I want you to think and evaluate if the toolkit interventions would work in your clinic and why or why not. And then in the light of, in the spirit of this whole presentation, what questions do you have? All right. Do we have any questions?
All right, Lisa, thank you very much. I appreciate that. We have a lot of questions. And I don't know if you have a particular place that you want to start, but I'll go ahead and I'll throw up what are some of the most common ones, if that's okay with you.
Yeah, that would be great.
Great. I think the first one we saw a lot of questions that were anticipating what you ended up talking about at the very end, which was the length of time of the visits. I think people thought that this would be a time-intensive activity. How do you explain the fact that you did not see that, that this did not take any more time?
You know, I'm going to say, I think humans are really good at adjusting to the situation. And I personally, like when I'm doing these let's take the brown bag medication review, because to me, that was the biggest time sink, right? So instead of chatting about somebody's grandkids or something like that, while we're just like getting to know each other, I may be chatting about the grandkids while I'm rifling through their bag of medications. So I think that we make things fit. That's my best explanation of that one.
And a related time question that comes from the audience is, does any of this happen in a more natural fashion if you extend the time of visits? So some of this is obviously something you've layered on top of, would have been already shortened visits for all of us. Does any of this happen naturally if those visits are just extended for new and old patients?
I would hope so, right? I would hope that we are asking, what questions do you have? Tell me what you understand about your disease. I would hope we would ask those things. Again, the medication brown bag review, those were challenging. Those were super challenging to get people to actually bring in their medications. And I pull those out of my bag of tricks rarely now at this point. I will say to a patient that I just feel like I'm not communicating with, or that we're not getting it. There's some mismatch here. I'll say, hey, can you please bring in your medications next time so we can go over those?
Related question having to do with exactly that issue, which somebody in the audience noted was, despite the phone calls from the study coordinator, et cetera, 30% or so of patients, having been contacted, still didn't bring their medications, which raises the question, that may not be a literacy issue at that point. What do you think is behind that, and what else needs to be addressed for that patient population? Did that ever get sort of sub-studied?
So I had some patients who told me, I just don't want to bother. They literally said, I don't want to bring in my bag of medications on the bus, or I'm afraid they're going to get stolen. There have been a lot of concerns about that. And then some of it just felt like it was a real pain in the tuchus. So I think there's that aspect of it. And then, to be very frank, I think there's a lot that we don't understand the concerns about, or we don't understand why this was going on. And I think that could be evaluated through a different means, interviews, things like that.
That's great. Thank you. There's a number of questions from the residents at the various sites. And one of them, because I think they do as much primary care as subspecialty care, is how does this apply in primary care clinics?
I would propose that we should all have the conversation with all of our patients. And, this is a blanket statement. Take it for what it is. This is 100% a blanket statement. But I would propose that if we say to our patients, we've talked about a lot today. Tell me what you understand about our discussion. That it will be a mind-blowing experience for you. You will say, wow, I thought I was communicating and I was not. I've had that experience so many times, but I think that in primary care, you can have that experience also. I think you can say, you have high blood pressure. I want you to take this medication. And then when you ask the patient what they understood, they're going to tell you something completely different than what you thought you said.
Mm-hmm. And the same group of residents has a related question, which is, what about the follow-up after this study? So obviously, this was all under the microscope. It was while you were watching. It's while you had coordinators. Did you look to see if these behaviors continued? Did the toolkit persist after the study, or do we not know that yet?
$1 million question, right? So I'm going to pull back the transparency, or pull back the curtains, give full transparency. So this is actually something that Dr. Hirsch and I are wanting to look at now. So without the microscope, without the pressure, what are people doing? What are people recording? What are people saying to their patients? Okay. And I have the data pooled, and I need to make the time to analyze this. I think this would be a great follow-up paper of saying, okay, are habits ingrained now? Are we making a difference? Is there still a continued change in the PDC? What are we looking at through this? And to be 100% transparent on my part, I kind of got blown up by COVID on doing the analysis. So this is next on my list of things to do.
Makes total sense. The other question gets at some of this, time constraint and other clinic pressures, and then how to offload those things. And so there's a couple of questions around, can you do this in a multidisciplinary fashion? Is there value in having the doctor do this? Do we know, what if somebody else were to ask these questions?
That is a wonderful question. I actually would love to have the money to be able to hire a nurse, an MA, somebody, a pharmacist, pharmacy tech, somebody who could follow my patients on a regular basis and say, hey, are you taking these medications? If not, why? What's going on here? Those sorts of things. In my heart of hearts, I don't think it matters from which source. I don't think it matters if it's the physician, or matters if it's a nurse, or if it's a medical assistant. But I think it matters that the patient understands that you care, you, the royal you, right? That is another way that this research could actually go, is if we had somebody who was making these calls and saying, okay, how are you doing? What's going on? What questions do you have? These sorts of things. And I think that would actually be a really cool intervention.
And there's a related question. Do you know, either in the rheumatology community or elsewhere, has it been studied using entirely separate visits for these activities? So saying there is one visit for one purpose, and if you're time stressed, you'd use an entirely separate visit to do these activities.
I believe, and this is back in my brain cells, my archives from several years ago when I was doing the background on this material, I believe that there is some data of having, let's just call a coordinator who's going over like warfarin, or who's going over adherence to thyroid medications. I believe there are some data out there, but I couldn't cite you a study this moment on that one.
Fair enough. I have a very specific and thoughtful question from Dr. Stitchman, one of your colleagues. And it's at the idea of the results that you saw is why do you think medication adherence improved without changing the CDAI? And it was that PGA driven. What made that improvement possible?
So I think that's a brilliant question, Jen. I think that's a wonderful question. I think it's more complicated. Frankly, I would have guessed at the beginning, it was my hypothesis, that by improving the CDAI, that we would by improving medication adherence, that we would improve the CDAI. That was my hypothesis. I thought I had a direct line to improving clinical activity of our disease activity of our rheumatoid arthritis patients. But I think part of it is that the CDAI is an imperfect measure of rheumatoid arthritis. I could give a whole 3 grand rounds on disease activity measures in rheumatoid arthritis and how complicated they are, and how I think that they need to be blown up and started from scratch. But I think what we're capturing, Jen, is I think we're capturing a lot of other aspects of patient's life, similar to our clinical case number 2, as opposed to only the disease activity.
Now we got another tailored question from one of your colleagues, from Dr. Kolfenbach. And he's asking specifically, I'll read the entire question, is the intervention, if he understands correctly, did improve medication adherence, but after controlling for self-identified race, it did not. And if he's understanding that correctly, why do you suppose that is? And what implications does it have for how we can help those groups of patients who are not reached by this intervention?
So that is actually a really good question, Jason. And I'm going to bring this up right here. Sorry, wrong one. Okay. So when we are looking at all these different measures, it's not so much that it did not help when you're looking at self-controlled race. It is saying that all these aspects are in part of this. Okay, so when we're looking at the CDI, oh, I'm so sorry. I misread your question, Jason. I'm so sorry. I was looking at the CDI, not looking at the medication adherence. I apologize. So this is looking at the PDC. So this is looking at the medication adherence. And then when we are looking at the teach back, and when we're looking at the self-identified race and ethnicity and those sorts of things. So when we are controlling for these different aspects, the teach back may not help people of African descent as much as it may help others. Okay. And then, the questions, your question is a good point, right? Is it because most of our people who were in clinic were white, right? We did not control for the race or ethnicity of the physicians. Okay. So could it be that the race of the physicians made a huge impact on this? It's very possible. And what interventions can we do? It'd be very interesting, I think, to focus in on teach back, because this has shown a signal here, and look at teach back when we're looking at pairs of a physician and a patient, and seeing if the gender or the ethnicity or the race of the physician impacts these discussions with the patient. I think this would be cool as heck.
So to be determined.
To be determined. I think
Yes.
There's a lot of work that can be done here.
Is great. I've got several sort of bigger and I would say harder questions, but there are ones that I think I'm really interested to have your insights on. Is it known, what's the relationship between health literacy and general literacy and numeracy, as you mentioned? So you sort of talked about there's level 1, 2, 3, 4, and 5 of the general things. Does that same degree of literacy, does that play out in a one-to-one fashion in terms of health literacy, or is health literacy so much more complex that it takes a sort of a higher baseline to even play in the game?
It is so much more complex. And to be very frank, there's not been, I didn't go into this because there's only so much time, but there is an actual test for health literacy, and it's the STOFLA. And there's a lot of other information out there about, like, there's a one item that Dr. Kinzano, so she's, if any of my colleagues are listening, that she worked on a paper with, that is a one item self-identified health literacy. And it's looking at, like, how comfortable are you? And most people are pretty good at saying, I am super comfortable, or I am not comfortable at all. So it's this one item thing. Health literacy is way more complicated than just literacy and numeracy. One of the examples I didn't put in here, but I thought about, I had actually a patient who was a JD, and her health literacy was not good. And I was never able to identify why. And I also would throw it out there that, if somebody has, for example, ADHD, or if somebody has other things going on that may make implications on their health literacy also.
A couple of questions about additional barriers to health literacy and health understanding. What do we know about the language barrier? So in terms of clinics that have easy access to interpreters, low access to interpreters, low uptake and usage of interpreters, how does that play out?
Yeah, so that is that could be another 3 grand rounds also. But there is a lot of association between limited health literacy and low English proficiency. So again, we're looking at clinics that are based in English speaking nations, right? And so if we were to look at clinics that were based in, that the providers all spoke Spanish, and you had a patient who is Spanish speaking, or if you had a translator or interpreter who was right there with you, I think that those would obviously impact the outcomes of that too.
There's a related question in the chat about provider adherence. So when a provider sees a patient who, quote unquote, speaks a little English and then conducts the visit in English, do you know what that looks like? Did you guys look in your clinics in terms of how providers made use of those other tools?
So we are pretty dang strict at Denver Health about even if you speak a little Spanish, that you need to get an interpreter. And most of the time, I would say people are pretty adherent to that. But that is a really good question. We're supposed to write in our notes, Denver Health interpreter, whoever it is, Victoria or whatever it is. But that is not an easy, we did not make that as a drop-down menu, like interpreter use, that sort of stuff. But I think that would actually be a very interesting variable to throw in there.
Another sort of big question, and I'll read this one in total for you, is we commonly see comparisons of country where healthcare dollars are spent and shown side by side with healthcare outcomes. Have such outcomes, or are such outcomes, corrected for literacy and numeracy of the population, given the profound impacts you showed of those two things here today?
I don't believe they are. I don't believe they are. I would have to dig into the methods, but I really don't think they are.
Interesting. Yeah, because it seems like it's obviously a huge factor. Yeah.
Mm-hmm.
Good. And then I have one other question for you, and then I want to throw it open for Dr. Chopra as well. Is there a source that residents and providers can go to put a toolkit like this into place in their clinic today?
I'll let you have first go at it if you want, Dr. Chopra.
I think that question was for you, not for me.
Yeah, that one's for you. He's got other things for you.
Nice try there, Dr. Davis. I have a question for you afterwards.
So the answer is yes, with an asterisk, right? So if you want to go to AHRQ and if you want to look at the toolkits that are out there and look at what the options are and use that as a QI measure in your clinic, and have a discussion with your clinic directors, et cetera, and then do an intervention, I think that would be cool as heck. And I will be, waving flags and saying, go for it. But I think, and this is part of the reason why we did this study, is while I think a lot of these seem like good ideas and seem like they would work, we don't have a lot of evidence of what they do. Right. And so this is part of the reason why we did this is we were looking at feasibility and we were looking at effectiveness, because it may make us feel good to do an intervention, but if it's not helping the patient, then why are we doing it? Right. And so I think that this is where we need to have more information as to the various toolkits around how effective are they.
Yeah. And so to encourage somebody who, while waiting for that data, wants to attempt to do what's best for their patients, and based on your data that it shows, there's reasonable evidence to suggest that it's going to help in some fashion, would you say copying a performance like this, like thinking about the things, which is encouraging question behavior, the brown bag check, the teach back. Would that be a reasonable place for people to start today?
I think it'd be a very reasonable, and I would go so far as like, I truly think that the brown bag is a little bit pie in the sky for a lot of our patients. If you only could do one thing, only one thing, I would say do the teach back and encouraging questions.
Makes sense. Dr. Tripp, I'll throw it over to you for a few minutes.
Thank you, Dr. Connors. Dr. Davis, that was awesome. As you can see from the questions, there's lots of interest in this topic in general. And then as you were talking, I was thinking about a different disease state that actually has a lot of similarity from what I see as a hospitalist, which is congestive heart failure. When you think about CHF and you think about people in the hospital and why they get readmitted, almost always there's some degree of medication, what we call non-compliance, what I think is the wrong term. It's actually our failure to actually make people compliant because they don't understand what they're supposed to do. And if you think about the learnings and readmissions in heart failure, a lot of it has been around this task specification. So there needs to be a pharmacist involved in the care plan period who's going over meds with every single visit. There needs to be a social worker who's working on their home situation so that that's part of their medical treatment. That includes things like diet and things like exercise and all the other things that go into sort of preventing heart failure readmissions. And I'm struck by how much of that is similar to what you said around providing support, maybe not within that 20-minute visit, which would be very hard in some ways. And the questions that you've heard are, how feasible is this? How realistic is this? But I think thinking about, moving out of our silos to team-based medicine so that we're actually meeting people where they need that type of care, I think is really powerful. And I wanted to add one more thing. And I was thinking about this aspect of teach back. So I'll tell you in my culture, and I'll actually reflect on my parents, when I've tried to do this with them, which I've tried multiple times, there's a hesitation to try to tell the doctor what you've learned in a way that you're teaching them, right? Like there's this barrier of, I am not here, or you're the boss. I'm not going to actually tell you what I just learned because that would be inappropriate of me to step into that space. You know this better than I do. So there's a humility there. And so as we think about concordance with race and culture, I think that, your idea of matching characteristics to patients is really important. It's not just about race. It's actually deeper than that, right? It's about culture. It's about expectations. And I think teach back is powerful, but teach back needs to be done in a way that it doesn't appear to be in some ways inappropriate or confrontational from a patient's perspective. I'd love your comments on that, because I can tell you from my experiences, it doesn't work very well in my culture. It's often seen as almost as a barrier to communicating effectively.
Yeah. And I think you're absolutely right. And I think that, again, I'm approaching this as a white woman who's lived in Arkansas and Utah and Colorado, right? I've lived at other places, but this is my experience. And many of my patients are white, but many of them are not. And I'm doing my best to communicate, but I could be inadvertently stepping on toes when I'm asking these questions.
That's great. And so I think the takeaway for me is asking people how best they learn is an important aspect of that conversation. Thank you.
Thank you.
That's great. Well, Dr. Davis, thank you so much for today and for taking all of those many questions we had. I really do appreciate it. And I appreciate all this insight. And I think that's some of the most engagement we've seen from the residents for sure. And so I know this is a hot topic for them because they are trying to reach patients in exactly this way in all their clinics. So thank you again.
All right. Thank you, guys. Thank you for inviting me.